Hi everyone, our subject today is failure to thrive in pediatrics. Basics. Failure to thrive or weight fluttering describe a pattern of growth that is also established standards for age and gender. Anthropometric failure to thrive is defined as any one of the following. Weight or weight for length height less than 2 standard deviation below the mean. Weight acceleration of more than 2 major percentile line after a previously established pattern. Weight less than 75% of mean weight for chronological age. Weight less than 80% of median weight for length. Weight for chronological age less than 5th percentile. Body mass index for chronological age less than 5th percentile. Length for chronological age less than 5th percentile. And one of these is considered failure to thrive. Prenatal history. Multiple miscarriage suggests genetic disorder, maternal health and or medical diagnosis, tobacco, alcohol, or illicit substance, other teratogens or toxin, prescribed medication, radiation exposure. Birth history, gestational age at delivery, weight, length, and head circumference, asphyxia, infection, other prenatal complication. Medical history, newborn metabolic screen result, medical diagnosis, reflux, cardiac disease, obstructive sleep apnea, respiratory infection, upper respiratory tract infection, other chronic or recurrent condition, hospitalization, surgeries, immunization, events at time of significant loss or weight or gaining of weight. Developmental history, personal, social, language, fine and gross motor milestone, loss of previously acquired milestone. Family history, weight, height of biological parent and sibling. Parental history of childhood growth delay. Medical, mental, and developmental diagnosis of parental and sibling. Maternal postpartum depression, caregiver use of illicit substance. Review of system, activity level compared to peers. Chronic rhinorrhea, congestion, cough, mouth breathing, snoring, frequent awaking from sleep, difficulty or pain with sucking, chewing, or swallowing, vomiting or excessive spitting up, breathlessness, sweating or tiring during feeds, frequent large blood or oil stool, constipation, urinary frequency or dysuria, polyuria, polydipsia, polyphagia, eczema or urticaria exacerbated by selected food. Psychosocial history, difficulty purchasing or preparing food, distraction during feeds, meal, perception of child behavior during meal, eat habits of a sibling when a similar age as infant child with failure to thrive, individuals and family stressor and strength, supplemental food and community resource, travel to less developed countries. Dietary history, frequency, duration of active suck, frequency, type, preparation, quantity of typical formula feed, feeding change at night or on weekend, age of weaning, shift in feeding practice, food consuming over typical 24-hour, water, juice, soda over typical 24 hours, food allergies or intolerance. Food allergies or intolerance, feeding habits and technique, bottle propping, grazing, eating habits outside the home, daycare, school, vitamin, herbal, other supplements. Physical examination helps identify chronic illness, syndromes, weight, length, height, head circumference, vital sign, pain, general activity level, lethargic, hyperactive, caregiver-child interaction, eye contact, physical approximation, checking, hygiene, dysmorphic feature, lymphadenopathy, head, dry, dull, or absent hair, fontanelle size, eyes, palpebral fissures, conjunctival pallor, strabismus, cataracts, retinal hemorrhage. Ears, malposition, otitis media, mouth, throat, anatomical abnormalities of palate or tongue, glossitis, chelosis, gum bleeding, thrush, dental abnormalities, enlarged tonsil, cardiac, murmur, abnormal femoral pulses, chest, lung, retraction, wheezing, crackles, GIT, distension, masses, hepatomegaly, anogenital malformation, severe rash, anal fissure, hemorrhoids, musculoskeletal, frontal bossing, rachitic rosary, extremity bowing, wrist widening, edema, decreased muscle mass, skin eczema, hives, scaling, spooning, spoon-shaped nail, patterned bruises, scar, burns, neurological cranial nerve palsies, hyper or hypotonia, retention of primitive reflexes. How to approach to child with the failure to thrive and weight loss. Perform history and physical examination, accurate documentation of serial measurements, sign or symptom suggestive of developmental delay or neuromuscular disorder present. If it is yes, careful review feeding history, assess calorie intake, consider torch titer, speech pathology, consult. The differential diagnosis, developmental delay, multiple etiologies, inadequate intake, inadequate calorie intake, oral motor dysfunction. If there is no abnormal sign or symptom, no developmental delay, no neuromuscular disorder present, is there sign or symptom suggestive of organic etiology present? If it is no, careful review feeding history and technique, psychosocial issue, nutritional intervention. Differential diagnosis, if the diagnosis apparent, inadequate intake, breastfeeding problems, improper formula preparation, improper feeding technique, insufficient food offer, food insecurity, inappropriate parental knowledge or expectation, aversion, pain, sensory, other psychosocial factor. If diagnosis not apparent, complete blood count, lead level, blood chemistry profile, urine analysis and culture, albumin and serum protein, celiac panel, anti-tissue transglutaminase and IgA. Review newborn secrete result, consider sweat chloride test, free T4, TSH. If it is abnormal result, differential diagnosis, renal disease, obstructive uropathy, reflex nephropathy, reflex tubular acidosis, glomerulonephritis, liver disease, celiac disease, cystic fibrosis, other causes of malabsorption. If it is normal result or diagnosis apparent, patient need continue nutritional intervention, consider referral to multidisciplinary feeding programs versus inpatient observation. If diagnosis not apparent, consider organic disorder. If the history or physical examination evidence suggesting organic etiology. If there is excessive spitting up, vomiting, see previous lecture of vomiting, consider upper GI series, pH probe study, metabolic workup, differential diagnosis, obstruction, WEPS, vascular ring, pyloric stenosis, bizarres, malrotation, volvulus, gastroesophageal reflex, rumination, increased intracranial pressure, allergies, IgE mediated or food protein induced non-IgE mediated reaction, encephalopathy, lead hypoxic ischemic encephalopathy, Hirschsprung disease, meconium ileus, or metabolic disorder. If there is diarrhea or abnormal stool pattern, foul smelling, bulky, abdominal distension, cramps, see previous lecture of diarrhea. Consider stool fat, ova and parasite, celiac panel, antigen studies for giardia and cryptosporidium endoscopy with a small bowel biopsy, sweat chloride, zinc level, differential diagnosis, celiac disease, other food protein-induced hypersensitivity reaction, parasitosis, giardiasis, cryptosporidiosis, eosinophilic intestinal disorder, esophagitis, gastroenteritis, inflammatory bowel disease, liver disease, hepatitis, cirrhosis, biliary disease, Hirschsprung disease, pancreatic insufficiency, cystic fibrosis, Schwachman-Diamond syndrome, short gut syndrome, other rare causes of malabsorption, disaccharidase deficiency, other congenital disorder, HIV, other immune deficiency, acrodermatitis enteropathica. If there is a frequent infection, minor or serious, see previous lecture of recurrent infection and immune deficiency, either HIV or other immune deficiency. If there is snoring, periodic breathing during sleep, restless sleep, lateral neck film, ENT consultation, differential diagnosis, upper airway obstruction, adenotonsillar hypertrophy, micrognathia, retrognathia, nasal obstruction, core pulmonary, secondary of course. If there is respiratory symptom, coughing, wheezing, consider chest x-ray, radionucleotide scan for aspiration, PPD, tuberculin skin test, sweat chloride test, differential diagnosis, chronic aspiration, GERD, cystic fibrosis, congenital or acquired heart disease, including cardiomyopathy, severe asthma, tuberculosis, HIV, pneumocystis carinii, pneumonia, lymphoid intestinal interstitial pneumonitis, or bronchiectasis. Other, like eating disorder, other causes of anorexia, congestive heart failure, malignancy, HIV, hyperthyroidism, diabetes mellitus, or other chronic disease. Recommended investigation: urine for proteinuria and renal disease, complete blood count, low hemoglobin suggests anemia in malnutrition, infection, and malabsorption, serum albumin, inflammatory marker, C-reactive protein, and ESR elevated in infectious disease, thyroid function test will confirm hyperthyroidism, celiac secrete. Consider cranial MRI if no cause for weight loss has been identified. Top tips: small for gestational age babies, weight less than the 10th percentile for gestational age, dated from the first trimester, symmetrically affected in the height and head circumference as well, often remain underweight. They should not be categorized as failure to thrive. Malabsorption is characterized by diarrhea of greater than 4 stool a day and or steatorrhea, like fat content in the stool more than 4 grams per day for infant and more than 6 to 8 grams in older children. Neglect, whether nutritional or emotional, is the most common cause of underweight in infancy and may account for more than 50% of causes of failure to thrive. Community pediatricians have a central role in the care of children with the chronic illnesses and in supporting their families. The main role of pediatrician is establish a diagnosis and arranging referral to subspecialists and other medical facilities. Depressive disorder is not uncommon in adolescents who may show either a decrease or an increase in weight. Red flag. Children who are small for their gestational age often have a slow weight gain during the first 1 to 3 years for their life. They have to be differentiated from those who have gaining weight and then experience weight loss. The latter group should be taken very seriously. Be aware of children at a high risk of abuse, excessive crying during infancy, physical handicap, chronic illness with behavioral or learning difficulties. Early detection of psychosocial problems like neglect is very important because it can result not only in poor physical growth but also in poor cognitive and intellectual development. Neglected children returning to their parents without any medical or social intervention may face serious re-injury in about 25% or death in about 5%. Weight loss in adolescent girl is likely to be due to eating disorder. Diagnosis can be difficult in the early stage. Asking about attitude toward eating and weight will suggest the diagnosis. Most causes of developmental delay can result in failure to thrive. Even mild neurological disabilities can significantly impact a child's ability to achieve adequate caloric intake. A small head that predate the failure to thrive suggests a perinatal insult such as hypoxic ischemic encephalopathy or a congenital viral infection including HIV. Dysmorphic features suggest chromosomal abnormalities. Prenatal exposure to anticonvulsant or alcohol are also risk factor for developmental delay and failure to thrive. Other diagnoses to consider include neuromuscular disorder, congenital syndrome, and metabolic disorder. Special consideration is required regarding the expected growth and calorie need of children with more severe disabilities. Subcutaneous fat, triceps skin fold measures may be a more appropriate growth assessment than a growth chart parameter for some of these children. Oral motor dysfunction is a common in children with the developmental delay of any severity. The condition may be subtle and tend to manifest when a child begins taking more textured solid food. Evaluation by a speech pathologist, including a video fluoroscopy swallow study, may be necessary. Although organic causes of failure to thrive are more the exception than the rule, a careful history and physical examination will usually suggest an underlying medical problems if present. Any disease, depending on the severity and chronicity, may produce failure to thrive. An in-depth diet and feeding history should include dietary content, food types, volume, preparation, as well as inquiries about how easy the child is to feed, food abbreviation, parental anxiety, and misconception about feeding cues or appropriate nutrition can all contribute to inadequate calorie intake. Asking parents to provide a 24-hour dietary recall or a food diary for 2 to 3 days is often helpful. Quantify water, milk, and juice intake. Ask about formula preparation and substitution and the process of feeding and meal times in the household. For example, ask about whether everyone is in the family eating their meals together and whether any distractions are present during meals. Nutritional intervention should begin at the time of the assessment. Nutritional education and counseling should be provided to parents, ideally with the assessment of the nutrition. Other psychosocial factors contributing to inadequate calorie intake include family, mental health disorder, substance abuse, and other family chaos, homelessness, intimate partner violence, unemployment. Neglect can occur when parents perceive a child as having a difficult temperament or being poorly responsive when feeding. There is no recognized ideal panel for screening tests for failure to thrive. Ideally, tests should be considered according to the suspected disorder. The algorithm listed a reasonable selection for when no clinical diagnosis is suspected. Review of the newborn screen should provide result of screening for celiac, cystic fibrosis, and congenital hypothyroidism. Most newborn screening process use combination of the immunoreactive trypsino gene level and limited DNA testing to identify children with the cystic fibrosis. Confirmatory sweat analysis is recommended when the results are abnormal. This approach is about 95% sensitive. If a cause is not apparent after through history and physical examination, preliminary laboratory evaluation, and no improvement has occurred with the initial nutritional intervention, involvement with a more intensive multidisciplinary team is ideal, if available, of course. Therapist, nutritionist, social worker, speech pathologist, and psychologist or developmental specialist can all make valuable contribution to the management of child with failure to thrive, regardless of the cause. The availability of such comprehensive team is, however, limited in most places. Hospitalization is indicated in cases of suspecting abuse or neglect for the purpose of ensuring patient safety, in extreme cases of malnutrition in which a child is at risk for refeeding syndrome, and when more intense surveillance is needed because outpatient evaluation and intervention has not resulted in any improvement. The benefits of hospitalization are limited by short stay due to payer mandates and the multiple variables an inpatient setting creates. Long-term outpatient and in-home therapies are preferred options. When a period of multidisciplinary involvement and observation still fail to improve growth and or suggest an etiology, further consideration should be given to organic disorder, especially those that may present with the subtle symptom. Assessing for malabsorption disorder is reasonable because they may occur without obvious diarrhea. Also remember that gastroesophageal reflux can be present without obvious spitting up or vomiting. If gastrointestinal causes are not identified in a child with a history of vomiting, neuroimaging should also be considered, since increased intracranial pressure due to a variety of etiologies, including abusive head trauma, may be the cause. Food protein-induced septum, enterocolitis, proctolitis, enteropathy are non-immunoglobulin IgE-mediated hypersensitivity reaction that can manifest as vomiting and or diarrhea with a wide range of clinical severity and usually begin in infancy. Children with the Hirschsprung disease may have a history of delayed passage of a meconium, Down syndrome, or positive family history. Most cases will be diagnosed in the first day of life with the abdominal distension, vomiting, constipation. Occasionally, older children will present with failure to thrive, abdominal distension, and constipation. A few will demonstrate intermittent diarrhea, absent stool on rectal examination, and immediate passage of stool and gas after the rectal examination are also suggestive. A rectal section biopsy demonstrating absent ganglional cell is necessary for diagnosis. Inborn error of metabolism is in the neonate are typically severe and life-threatening. The infants are usually normal at birth and often rapidly deteriorate over the hours to days after their birth. Signs and symptoms are nonspecific and include vomiting, lethargy, poor feeding, convulsion, and coma. These infants are often presumed to have sepsis. The physical examination may be normal or may reveal signs related to CNS, hepatomegaly, or occasionally a characteristic odor that may aid in diagnosis. A high index of suspicion is necessary and should be increased by the history of consanguinity and or a family history of neonatal death. For a metabolic workup, blood and urine should be obtained during episode of suggestive symptom. A blood test should include complete blood count, electrolyte, calculate an ion gap, ABG, glucose, ammonia, lactate, carnitine, acylcarnitine, and serum amino acid. Urine should be analyzed for ketone, reducing substance, organic acid, and carnitine. Consider amylase or lipase, particularly in older children who also complain of abdominal pain. Mild variants of most inborn error do occur and have an insidious presentation. Be suspicious when there is a history of unexplained mental retardation, seizure, and unusual odor, especially if manifest during an acute illness, or a family history of metabolic disorder or unexplained infant death. Some children will experience intermittent episodes of severe illness, including unexplained vomiting, acidosis, and mental deterioration or coma. Celiac disease is the most common food protein-induced enteropathy. It typically presents as intestinal symptom, diarrhea, bloating, failure to thrive, irritability, poor appetite in the first 2 years of life after the introduction of gluten-containing products, wheat, rye, barley, and other grains into the diet. Anti-tissue transglutaminase antibody is the preferred screening test in most institutions, and IgA endomysial EMA antibody titer is a reasonable alternative. Be aware that anti-tissue transglutaminase may be absent in 10% of children younger than age 2 years with the celiac disease. Checking total serum IgA is also recommended because IgA deficiency is a common in celiac disease. If present, additional serology or intestinal biopsy may be necessary for diagnosis. Cystic fibrosis may manifest at birth with the meconium ileus or later with the steatorrhea, failure to thrive, and cough. Not all cases develop pancreatic insufficiency. Of those that do, the malabsorption may be not evident until after neonatal period. Schwachman-Diamond is characterized by pancreatic insufficiency and chronic neutropenia. Even the most exhaustive effort and thorough evaluation may occasionally fail to determine the cause of failure to thrive. Maintain involvement and recurrent evaluation over time may be the key to the diagnosis. Eating disorder should always be carefully considered in adolescents regardless of associated complaint. In children without other obvious associated disorder, iatrogenic causes of anorexia, drug therapy, unpalatable therapeutic diet, and depression should be considered. It is important to inquire about risk factor for HIV because it may present only as failure to thrive with lymphadenopathy and developmental delay. Associated infections are not always present. Nearly any chronic disease can lead to failure to thrive, secondary either to altered intake, increased need, or excessive irritability.